This meeting is now being recorded.
Good afternoon, everyone. I would like to present to you my capstone project entitled Correlation of Evaluation Methods Determining Nurse Competence in Critical Care Registered Nurse Residents. This pilot study described the correlation between instruments used to evaluate nurse competence. The evaluation of nurse competence was one of the processes occurring in a newly established critical care RN residency for a rural hospital in Washington State. Since the 2010 Institute of Medicine report, The Future of Nursing, residencies are becoming more commonplace. However, content varies widely, and the tools to evaluate the skills, knowledge, and attitudes of the nurses completing the residencies are not comprehensive. This pilot study explored the correlation of 3 instruments used to measure clinical competence in nurses new to critical care. To more fully understand the study, here are a few of the problems noted. Critical care nurses provide care to the highest acuity patients in the hospital setting. Providing such specialized nursing care requires orientation opportunities to facilitate the greatest amount of learning and to narrow the gap between basic and specialized practice. Many CCU vacancies are being filled with newly licensed nurses, nurses with no acute care experience, and nurses with acute care but no high acuity care experience. The diversity of the level of nurses entering the CCU is challenging when developing an orientation residency. Another challenge is to develop formative and summative evaluations of the clinical competence for each nurse participating in a critical care residency. This pilot study examined correlations between 3 instruments with tested reliability and validity used to evaluate nurse competence. Now I will provide more background for this pilot study. The study hospital had 6 vacant CCU positions posted for more than 6 months without receiving experienced RN applicants. This was congruent with the concern that RN supply in Washington State is expected to fall far short of the demand over the next decade. The populations of critically ill or injured patients have grown, the severity of illness has increased, and the length of stay has decreased. The combination of these factors results in the need of expert nursing care that is becoming more challenging to find. The purpose of this pilot study was to explore correlations between 3 instruments with tested reliability and validity used to evaluate different aspects of RN competence. The competence of the RNs were measured before and upon completion of a critical care residency program to explore whether the strength of any correlations between the instruments is influenced by the critical care residency program. The instruments will be discussed in more detail later in this presentation. The Quality and Safety Education for Nurses Institute, known as QSIN, has developed a framework providing comprehensive, competency-based resources to empower nurses with knowledge, skills, and attitudes necessary to improve quality and safety across health systems. Many instruments used to assess clinical competency of nurses new to clinical areas, specifically to critical care units, lacked comprehensive assessment of knowledge, skill, and attitude. Additionally, there were a limited number of instruments tested as reliable and valid measures of clinical competence. A combination of methods may be needed to ensure a comprehensive assessment of clinical competence. The 3 instruments used in this research each measures a different aspect of the QSIN-identified qualities of RN competence. The research question reads, how do these instruments measuring different facets of nurse competence correlate before and on completion of a critical care residency program? The theoretical framework for this pilot study was Tanner's clinical judgment model, which provided a basis for investigating the development of nurse competence. This model emphasizes the integration of the roles of noticing, interpreting, responding, and reflecting in the development of clinical judgment. Tanner's model is also aligned with the CUSIN-identified nurse competence aspects of knowledge, skills, and attitudes, and with the 3 instruments selected for use in this pilot study. The scope of this pilot study was limited to 1 CCU within a rural community hospital and 1 cohort of resident RNs. The sample was one of convenience. Because of these limitations, the study may not be reflective of the general nursing population or practice settings. Additionally, the researcher, being influential in the workplace of this pilot study with direct impact on the evaluation of the employee participants, was a limitation. However, mitigation of potential complications was vetted with the IRB representing the employees of the hospital. The purpose of my literature review was to appraise methods to evaluate nurse competence with emphasis placed on nurses new to critical care and evaluations using comprehensive measures. The review of nursing literature highlighted the complexities of choosing specific processes and instruments to measure nurse knowledge, skills, and attitudes, and revealed major themes related to measuring nurse competence. This quantitative correlational pilot study used a paired sample t-test utilizing a one-group pre-test, post-test research methodology. 2 of the instruments had ordinal scales with the rankings of 1 through 4, and so were used in this study as interval measurements. Similarly, the 3rd instrument had score ratings possible from 0 to 100 and was also classified as interval data. The Pearson test of correlation was used as the variables were categorized as interval scales, were related to each other, and were assumed to be normally distributed. The Pearson correlation coefficient was a parametric test used to determine whether a linear association, a correlation, existed between the instruments used in this study. The Pearson correlation coefficient and other statistical analyses were conducted using Microsoft Excel and MyStat, a statistical software program. The pilot study design included pre- and post-residency program measurements obtained using 3 quantitative instruments. Participants in the CCU residency included RNs with a variety of experiences and consisted of newly licensed nurses, nurses with no acute care experience, and nurses with acute care but no high acuity care experience. The residents were current employees of the study hospital in good standing well beyond the probationary period with more than 6 months of independent practice in the progressive care unit. IRB permissions were obtained prior to the initiation of data collection beyond the usual and customary practices during new hire orientation. Consent prior to beginning the CCU clinical component of the residency was given by all 8 residents for this pilot study. As a measure of knowledge, the basic knowledge assessment tool with the critical care version known specifically as BCAT-8 was administered to all new hires to the CCU and was administered again upon completion of the residency. To measure skill, the Lassiter Clinical Judgment Rubric was scored by this researcher while observing each resident nurse providing care at the beginning and again near the completion of the residency while orienting in the CCU. Then Sections 1 and 2 of the Casey Fink Graduate Nurse Experience Survey were utilized to gain insight into the attitude as self-perceived by these nurses regarding their practice ability. Permissions were obtained from the creators for the use of these instruments in the manner described here. Briefly, I will describe each instrument chosen for this study. All 3 had documented reliability and validity as noted by the Cronbach alpha coefficients here. The BCAT-8 is a paper and pencil instrument consisting of 80 multiple choice and fill-in-the-blank questions. The instrument measures recall of information. That is, it measures knowledge related to critical care nursing practice. The Lassiter Clinical Judgment Rubric was scored by this researcher for each resident nurse at the beginning and end of their clinical components of the residency program while providing care to patients in the CCU. This rubric used a 1 to 4 Likert-type scale to quantify skills demonstrated by the residents. Then the Casey Fink Graduate Nurse Experience Survey gathers many self-perceptions of the new nurses' experiences, including ease or difficulty with specific skills and integration into the team through a quantitative format ranking attitudes. The survey used a Likert-type scale of 1 to 4. Next, I considered the details of the data collection plan. The RNs hired for the critical care residency were told about the pilot study and chose to participate in the study by signing a study-specific informed consent form. 3 distinct quantitative instruments were used to obtain data related to clinical competence in this pilot study. The instruments were linked to the participants through the use of a 3-digit code obtained from a random numbers generator and the creation of a key by this researcher. Data management was carefully considered to protect the confidentiality of the study participants as noted in this slide. Then I considered the detail of the data analysis plan. This correlational study utilized Excel for code books and descriptive data analysis, with MyStat being used for additional data statistics. The Pearson test of correlation, known as R, is a parametric test used to determine whether a linear association exists between two measures. For this pilot study, the critical value to determine a correlation was 0.582, as indicated from the Pearson correlation coefficient table. Next, I thought through ethical considerations as noted briefly on this slide. And then to the results. The purpose of this pilot study was to explore correlations between 3 instruments used to evaluate knowledge, skills, and attitudes of RNs before and upon completion of a critical care residency program. As you may remember, the critical value for this study was 0.582. Had this pilot study had a sample size enough to produce statistical power, correlations would have been significant if the R value exceeded 0.582. Prior to the residency, there was a significant correlation between the attitudes of the residents as measured by the Casey Fink survey and skill as scored by the Lassiter rubric, with the Pearson correlation coefficient computing a positive correlation of R equals 0.69. There was no other significant correlation between the instruments before the residency. The Pearson correlation coefficient found no significant association between the 3 instruments in the post-residency group, as noted here on this slide. Here you will see a correlational matrix for this study. The correlational matrix is a visual display of the coefficients of the 3 instruments and provides an overview of all the relationships being studied pre- and post-critical care residency. Essentially, this is a summary of all the correlations found among the study instruments during this study. The design of the study provided 6 opportunities for correlational evaluation. Of the 6 measurements, only 1 achieved correlational significance with an R of 0.69, being between the pre-residency Lassiter and the Casey Fink. This is a strong correlation, as the critical value needed to reach significance was 0.582 for this study. This indicates the residents' self-perception of performance and the observations of clinical abilities as measured by the researcher had a positive linear relationship. There were no other correlations of significance between the other instruments before and after the residency. To further discuss the relevance of this pilot study results, we return to the theoretical framework for this pilot study, being Tanner's clinical judgment model, which provided a basis for investigating the development of nurse competence. This model emphasized the integration of the roles of noticing, interpreting, responding, and reflecting in the development of clinical judgment. Tanner's model is also aligned with the CUSIN-identified nurse competence aspects of knowledge, skills, and attitudes, and with the 3 instruments selected for use in this pilot study. This slide shows how these facets are all interconnected. This pilot study found that the BCAT-8, the Lassiter rubric, and the Casey-Fink did not have significant correlations when administered to study subjects after completion of a critical care residency. Therefore, one of these instruments alone is not sufficient as a representative measure of nurse competence. This pilot study demonstrated multiple instruments are necessary to measure the different domains of nurse competence, as there was found to be little correlation among the 3 instruments used in this pilot study. Had there been strong correlations between the 3 instruments, the results would support the use of using only one instrument as a representation of overall nurse competency. Only one correlation existed out of the 6 opportunities in this pilot study. Does this study have significance to the nursing profession? This pilot study did not have statistical power to reach statistical significance. However, if there had been statistical power and through the review of nursing literature, it is apparent evaluating nurse competence is important for nurse leaders for several reasons, not the least of which is the profession's responsibility to protect the public. Additionally, nurses who lack competence can create hazards for the hospital in terms of patient outcomes, productivity, and cost. New nurses may experience lack of confidence, inability to efficiently prioritize multiple competing tasks, and fail to manage a typical patient assignment. The challenge to leadership is to support and facilitate the development of staff abilities in all dimensions of nursing practice. Newly graduated nurses and nurses new to specialty areas need support and feedback to facilitate clinical practice competence. Competence is multifaceted, and as nurses are supported in efforts to develop collaborative relationships, effective communication, coordination of clinical skills, and advanced evidence-based practices, the confidence and competence of nurses will flourish. Facilitating the growth of these competencies through professional development and higher education are foundational to the development of personal confidence, which in turn is essential to expanding leadership and higher level thinking. As nurses learn more, gain more experience, and succeed at challenges and weather disappointments, their abilities and capacities will expand. Providing structures and support for nurses to build experiences will expedite individual competence as well as increase abilities within the workplace. The recommendations for future research include replication of this study with A, larger sample size, B, experienced nurses, not just newly graduated nurses, in a new clinical setting, C, clinical settings other than critical care, and D, in a non-rural hospital setting. To summarize, the theoretical framework for this pilot study was Tanner's clinical judgment model, which provided a basis for investigating the development of nurse competence. This model is aligned with the CUSIN-identified aspects of nurse competence being knowledge, skills, and attitudes, and with the 3 instruments used to measure each aspect in this pilot study. This pilot study demonstrated having more than one measure of competence is needed to provide the depth of assessment required to accurately evaluate and support the ability of novice nurses. Formative evaluation using feedback from multiple sources with differing instruments is foundational to the success of new nurses integrating with the team and with independent nursing practice. Many individuals, from new nurses and nurses new to a specialty area to hospital administrators, may appreciate and see the value in having a more comprehensive means of evaluating clinical competence. Managers of nurses may have confidence in knowing nurses have undergone a comprehensive assessment of ability, and clinical educators have formative information to facilitate individualized orientation programs. In addition, when patients enter any healthcare arena, they have the assumption or the belief that all who treat them know what they are doing and will cause no harm. This assumption of competence is prerequisite to patients having trust in healthcare organizations. There is an ethical responsibility of healthcare leaders to ensure the competence of those who provide care. Patients may rest assured the nurses providing care are capable and have measured success when leaders implement a comprehensive evaluation of nurse competence. This is a list of my references. And with that, I thank you very much.